When a patient is having a heart attack, the most critical minutes aren't spent in the hospital. They're happening right here in the back of the ambulance. The medications we choose, the interventions we perform, and the hospital we transport to can mean the difference between survival and catastrophic heart damage. Welcome to episode 3 of Heart on the Line. In the back of an ambulance, we often have a limited toolkit, but the right tools used at the right time can stop a heart attack in its tracks. Today, I'm going to break down exactly what happens in pre-hospital treatment and why each decision matters. For decades, oxygen was that main tool, always the first tool that we would use in cardiac care, until we started to discover that too much oxygen might be a problem. A little backstory is oxygen is a vasoconstrictor. Giving it when the patient doesn't need it can reduce blood flow to the heart, the exact opposite of what we want in this case. If the patient is already oxygenating well, throwing on a non-rebreather mask won't help. It might actually make things worse. If the SpO2 is below 94%, then we want to give oxygen, or if your patient is showing signs of respiratory distress. If the SpO2 is above 94%, we're going to avoid oxygen to limit the chances of causing vasoconstriction with too much oxygen. The rule is simple. Only give oxygen when the patient is showing signs of hypoxia or respiratory distress. Aspirin is one of the most powerful tools that we have at stopping a heart attack. But why is that? Let's take a closer look. Think of platelets like tiny emergency workers. When a blood vessel is damaged, they rush in to form a clot. Normally, this is a good thing. But in heart attacks, platelets are clogging a blocked artery, making things worse. Aspirin stops those platelets from being able to clump together against that clot, making the clot larger. So this is really simple. All you need to do is give your patient 160 milligrams to 325 milligrams of aspirin, chewed and swallowed, and this would hopefully reduce the size of the infarction. Now let's talk about nitroglycerin. Nitro works by relaxing blood vessels, reducing the workload on the heart, and improving blood flow to the ischemic areas. But nitroglycerin isn't for everyone. If the heart attack is affecting the right ventricle, nitro can actually tank their blood pressures. That's why we always check a BP before giving it, because nitroglycerin is contraindicated in patients that have hypotension. When we see S&T elevation, we have one job: get the patient to a PCI center. But what does that actually mean? Imagine a heart attack is like a multi-car accident blocking a major highway. Traffic is piling up behind it, and if it isn't cleared fast, it could cause a disaster. PCI, or percutaneous coronary intervention, is kind of like the emergency workers that go in, take whatever that blockage is, and lift it right out of the highway, so that way flow can be restored immediately. In a PCI center, a cardiologist threads a catheter into the blocked artery, inflates a balloon to clear the obstruction, and places a stent to keep it open. The faster this happens, the more the heart muscle we can save. If we can get them to a PCI hospital within 90 minutes, that's where we need to go. But if not, we might need to consider thrombolytics. But either way, time is muscle. Pre-hospital treatment is all about buying this patient time. If you recognize a coronary issue early and start treatment early, you can buy this patient time before they get to a PCI and get the definitive treatment they need before heart damage is permanent. Next time, we're going to talk about the final step: handoff and hospital care. Thanks again for watching.